Dr. Corri Tannrikut, yay!
Hi, everyone. Nice to see you all.
So Dr. Tannrikut is a urologist from Shady Grove Fertility, and a urologist is a male doctor, so she deals exclusively with men and men's issues. So we're going to just chit-chat for a few minutes, give people a few seconds to log into the conversation, and then we'll get started. So how's your day been so far?
It's been great. The sun is shining, so can't complain. How about you?
Oh, my day has been outstanding. As you can see, I'm not wearing an official white coat for clinical purposes. I am wearing white to express my joy at spring finally arriving, even though it doesn't arrive until tomorrow. But I don't mind being a little early because I'm ready for some heat.
I like the enthusiasm. I'm on board with that.
That sounds great. And as always, at the end of the conversation, I will ask you to share what's in your Cade coffee mug. So what's in your mug? That's coming up later. You don't have to, you can keep it a secret for the next few minutes. Before we officially get started, I want to remind everyone that tickets are available for our Race for the Family, which is coincidentally hosted by Shady Grove Fertility, the clinic that Dr. Tannrikut is that she works for. And the 5K Race for the Family is a family-friendly event hosted at the Maryland Zoo. We will have a 5K walk, a 5K run, a 1.5-mile family fun walk. And we'll also have Savannah's Playground, which is an amazing children's play and education area at the finish line. We'll have lots of great information about ways to overcome infertility. And for everyone who registers or fundraises $40 in $40 increments, you'll get a ticket for a raffle for, drumroll, $10,000 in treatment from Shady Grove Fertility. So it's a fantastic event. Whether or not you are struggling with infertility and looking for community, you will have plenty of community on site. Whether you are an overcomer and you've already moved beyond infertility and you want to just give back to that community or just be a resource for others, come on out. If you have miracle babies, bring them out. And if you're not connected with infertility, but you just want to support an amazing cause, please join us. Saturday, the 16th of June, 2018, and more information is available at raceforthefamily.com. as well as cadefoundation.org, as well as shadygrovefertility.com. Okay, enough of my shameless marketing plugs, but I hope to see every one of you out at the race. So let's go ahead and get started. Dr. Tannrikut, am I pronouncing your name correctly?
You are. Oh, please call me Corri.
Corri, okay, great. So Corri, let's talk a little bit about urology. What is it?
So urology, generally speaking, is the study of the urinary tract in both men and women. I subspecialize in reproductive urology. So what that means is I take care of men and issues going on with their reproductive tracts. So for those men who are part of couples with challenges with family building, those men get referred to me for evaluation so we can try to optimize the chances of family building.
Excellent. That's wonderful. So you are dealing mostly with the body parts in the pelvic area.
That's correct. Exactly.
Okay, that's great. So, and I'll also add, for anyone who is interested, please send in your questions, send in your comments. We can post those live as the program is going on. So Corri will be answering questions live on air as this interview takes place. Okay, so, all right. How does urology, can you talk a little bit about some of the ways that the reproductive organs can cause infertility? Some things that may affect the reproductive organs that can cause infertility.
So generally speaking, in terms of testing, I'm looking at a semen analysis. We're really looking at sperm counts and movement of sperm. And if those numbers are low, how we can try to improve those numbers. So for example, there are things that some men do just in their general life
think you went out.
Can think about, so to speak.
Corri, could you repeat
Yes.
that? You went out for a second there.
Excuse me?
We couldn't hear what you said for a second there. The sound went out for a second there.
Sure. I was saying that we look at semen parameters and semen analyses to get a sense of the numbers of sperm that a man is producing, how well they swim, what they look like, what the shape is like.
Okay.
And there are lifestyle habits that some people have that may be impacting sperm production, sperm quality. Those sorts of things that we advocate that patients do in general for their good health, like avoiding tobacco use, excessive alcohol, trying to maintain a healthy weight, exercising moderately, all of those sorts of lifestyle modifications will only favorably impact sperm and sperm quality. There are some anatomic issues that some men are born with that also can impact sperm quality. So those are the sorts of things that we look for on physical exam when I see a patient in the office.
Okay.
Do you know what varicose veins are? Have you ever seen those big dilated veins that some people have in their legs?
Absolutely. Mm-hmm.
Some men have varicose veins in the scrotum. It's called a varicocele, and that's the most common correctable cause of male factor issues. So when I do a scrotal exam, that's one of the various things that I'm looking for, is if the patient has these dilated veins that may be impairing sperm quality.
So can you tell me a little bit about, so I want to backtrack because you had a lot packed in that answer. That's great. What's a normal sperm count? I think that, there's this perception that somehow sperm count is tied in with virility. Like if you're, the perception of manhood is connected with how many sperm you have. And, you would be able to share that that's just not true. There are probably plenty of football players and really strong men that may have sperm count issues or male factor issues. But can you talk a little bit about what a normal sperm count is? When you say motility, what does that mean for someone who just has no background? And then what is a normal sperm shape?
Sure. So when I'm interpreting a semen analysis, I'm looking at several parameters. And the first thing that I look at is the ejaculatory volume, the amount of fluid that's coming out. And if that's low, that can give us some insight as to whether there may be a blockage somewhere at the tail end of the reproductive tract, or if I need to be concerned about some sort of problem with how the ejaculatory reflex works. Once I've looked at the volume, then we look at the concentration. That's the numbers of sperm per milliliter. And normal is more than 15 million sperm per milliliter. So that's the number per milliliter we're looking for. And then we do a calculation to look at the total count, which is what you were asking about. We want at least 39 million sperm in that sample.
Okay.
Now, of the sperm in that sample, we want at least 40% to have some sort of movement. Motility is the movement of the sperm. And when we think about natural conception efforts, we're thinking about sperm being able to swim through the female reproductive tract to be able to find the egg after it's been ovulated. So that's why assessing movement is important. Assessing movement's also important because if we are thinking about doing fertility treatments, for example, insemination or IVF, which we can talk a little bit more about if you'd like in a moment, we're trying to get a sense of the numbers of moving sperm in the sample so we can help guide our couples with the best treatment approach. Are they candidates for something a little less aggressive? Do we need to do something a little bit more aggressive? And then finally, the shape of the sperm, the grading for this is very strict. We're looking at a lot of things. We're looking at the size and shape of the sperm head, the cap that's on the head of the sperm, the neck, the tail. Everything needs to look perfect for the sperm to be considered normal. And the shape gives us sort of a rough sense of the sperm's functional capability. Do we think that on its own, the sperm is capable of penetrating the egg in order to get to that next step of fertilization. So each of those parameters is really what I'm looking at when I'm interpreting someone's semen analysis to get a sense of where the problems may be or how we can try to improve things.
Okay, that's great. Can you also talk a little bit about whether or not this perception that sperm is connected with the masculinity of a man? I think that, again, there's some who believe that if there's a sperm issue, then somehow the man is less manly. And I don't find that to be correct, but you can talk a little bit about that.
Of course. No, I think that if a man is identified as having an issue with his sperm counts or motility, often they take that as a reflection of lacking in manhood, which absolutely is not the case. And there are lots of measures by which men, I think, have that inner reflection about manhood. Sometimes those patients who, for example, have sexual dysfunction look at that as a negative reflection of their manhood. And issues with semen parameters really aren't reflective of that per se. And what we're trying to do is help the couples conceive regardless of what the issues are. My goal, of course, is to optimize the man's general health, but also to prioritize their family building and how we can accomplish that.
That's great. So your manhood is independent of your sperm measurements. It's just medical. It's not moral, and no one is making a judgment about you as a man or as anything, regardless to what the sperm numbers show. So that's one takeaway I'd like all men who are watching this to remember. The sperm counts, the sperm measurements do not define your manhood or your masculinity.
Right. You
are more than your sperm.
Exactly. I may start using that line if I may.
Take it. Okay, so what are some of the signs or symptoms of infertility that may be male factor? What are things that people may start to see, or that should give them kind of an indication that this may be a male factor infertility?
That's actually challenging because one isn't normally looking at a semen analysis, right? There are very few external factors that a man may pick up on his own that may suggest an issue or problem. So many times I have someone come into my office to talk about very abnormal results, and it's never been on his radar that there might be a potential issue, and it only comes to light because he and his partner are having difficulties conceiving. Generally speaking, some of the more obvious issues or findings that a man may note is that if he's been told by his doctor in the past that the size of his testicles are small, that may be a bit of a clue that there might be a problem with sperm production, because the bulk of the volume of the testes are made up of the cells that are turning into sperm. So more often than not, smaller than normal volume testes are associated with some degree of problem with sperm production.
Okay. Now, this smaller than normal testicles and also the varicocele, are those issues that men are born with? Are they caused by something, stress or something that could have happened to them? Or, what causes these issues?
Sure. So varicoceles are something that someone is born with. They're not usually diagnosed at birth. Usually they become more obvious in late adolescence or early adulthood. Sometimes it's diagnosed by a pediatrician or a primary care physician. Sometimes the patient notices it himself. Varicoceles, when they're very large, can look like, we call it a bag of worms. It looks like a bag of squiggly little worms sitting on top of the testicle. So sometimes men will feel something or see something on their own self-exam and go to a doctor because they're worried that it could be testicular cancer or something. Alternatively, they may not have noticed any issues, and they're only coming to light. The varicocele is only coming to light because the patient is coming in and having an exam by me because of abnormal semen parameters. So a varicocele isn't anything that a patient has done to himself. Often patients will ask me, well, did I play too many sports? Was I lifting heavy weights? Did I cause this? they did nothing to control that. They can't control it. It's something that we just find in the general population. We find it in about 15% of the general population, but it occurs more frequently in men with fertility issues.
Yeah.
In terms of the smaller testes, generally speaking, it can be basically from birth if there's always been a fundamental issue with sperm production. And an astute pediatrician may actually notice that as the boy is going through adolescence and puberty, that the testes aren't growing the way that they're supposed to. So the pediatrician may initiate an evaluation either with a pediatric urologist or maybe an endocrinologist who's a hormone specialist to try to get a sense of why the testes aren't growing properly. Another circumstance that can cause the testes to shrink if they've been normal is if a man is using testosterone. So for those men with low testosterone, he may be prescribed testosterone, or sometimes people use it illicitly if they're bodybuilders. They may be using anabolic steroids. And what happens with that is these doses of testosterone that they're taking or giving themselves trick the brain. The brain thinks the testes are doing a really, really good job of producing testosterone. And normally the brain is sending signals to the testes to tell them to make testosterone. But if they see all of this testosterone circulating, the brain stops sending those signals. And when the brain stops sending the signals to the testes about making testosterone, it often stops sending signals to the testes about making sperm. So sperm production can decrease dramatically, even all the way down to zero in someone who's using testosterone. And we can see shrinkage of the testes in that sort of circumstance.
Wow. So men who use steroids it's possible that they would have their testicles get smaller and that they would decrease their sperm count. They would really impair their ability to have a baby. So, which is interesting because when you see these huge bodybuilders, I think that the idea for many is, they probably would be able to go out and get somebody pregnant just by looking at them. But, in fact, because of the amount of steroids that many of them are taking, they may in fact have fertility issues.
Right. And it gets back to your point earlier about manhood. I mean, you think about manliness with a really big muscular guy, but it's counterintuitive to think someone like that who may be using anabolic steroids may have no sperm.
Zero sperm. Mm. Okay. But if you have no sperm, you can go see Dr. Tannrikut. She is a fertility urologist. So this is all she does. She specializes in helping men with fertility challenges. So there is support available. So can we kind of jump to that? What are some of the treatments available for men first who may have the anatomical issue with the varicocele, or they may have been born with small testicles, and then taking that also out to men who may have caused infertility because of steroids, or and some of in any other treatments that you would commonly provide men?
Sure. So in terms of fixing a varicocele, that's usually a surgical repair done on an outpatient basis. So the patient goes home the same day. It's usually done under sedation or sometimes general anesthesia. And there are multiple different ways of doing the repair. The approach I use is what's called a microsurgical approach. So through a small groin incision, I can access the veins that need to be cut and tied off, and a microscope magnifies all of the veins and structures where I'm operating, so I can identify everything that needs to be tied off and preserve everything that needs to be preserved, so we can afford the best outcome for the patient and reduce risks at all. The goal of fixing a varicocele in my mind is to preserve testicular function where it is at that point in time. So there's no guarantee that we'll see an improvement in testicular function, but 65% of men after healing from the varicocele repair will have an improvement in testicular function. So their semen parameters will improve in the majority of men, which is why we think about offering repair.
That's great.
In terms of men who have a fundamental issue with sperm production, so I'm going to turn your smaller than normal volume testes into an inherent problem with the testes making sperm. That's really one of the most challenging issues that we deal with, but we can still offer treatment approaches to patients. So after a thorough evaluation in those circumstances, which includes some blood work and doing some genetic tests, we generally can offer the opportunity to try to obtain sperm directly from the testes themselves. So there are some men who have such severe sperm production issues that there are no sperm in the ejaculate, but they actually may have low-level sperm production going on within the testes. So what we do in that circumstance is, again, under sedation, using an operating microscope, get access to the testes through an incision in the scrotum. And basically we bivalve, we open up the testes under the operating microscope, and at 40 times magnification of what we can see with our naked eye, the microscope allows me to identify subtle differences between the tubules within the testis. So I can target taking those tubules that look more promising for containing sperm.
Okay.
We pass those samples off to a member of our andrology team. Those are people who read semen analyses as their job, so they're used to looking for sperm. And they give me real-time feedback as to whether we're finding sperm. And if we find sperm, we can use those sperm with IVF treatment. So it really offers those patients the opportunity to use their own sperm rather than consideration of a sperm donor. And it's wonderful when we can offer that and have a successful outcome.
Can you talk a little bit about men who would, at some point in their life, they may have undergone surgical treatment to prevent pregnancy, and then later on in life would decide, I want to have kids again. Is that a reversal that's usually successful? We've had many people ask about, should I go get a reversal before I go see a fertility doctor, because then I could get pregnant on my own? What, in your opinion, is the right decision?
That's a great question. There's no right answer to this per se. We're looking at the couple together and the nuances of what's going on with the two of them. So if a man has had a prior vasectomy, which is considered a means of permanent sterilization, and then changes his mind for whatever reason and wants to pursue additional family building, there are two options available. One is to consider reversing the vasectomy, as you mentioned, and I'll talk a little bit more about that in a moment. And the other is a surgical sperm extraction, not as invasively as I just described for the men with production issues, but any of those surgically retrieved sperm would be used for IVF. So when we're talking with the patients about reversal, and I actually counsel patients about all of the options so that they can take that information and decide what may be best for their particular circumstance. But when we're talking about vasectomy reversal, we want to keep in mind the age of the female partner, because that's the biggest predictor of likelihood of getting pregnant and having a live birth. We want to take into account their family building goals. How many children would they like to have? Are they thinking 1? Are they thinking 3? Because that has some bearing with respect to how they may approach the procedures. And we want to be confident that if we're going to do a reversal, that it will work. There is no shelf life, if you will, to how long it's been since someone's had a vasectomy and the idea of a reversal, but the likelihood of success measured by sperm returning to the ejaculate decreases the longer it's been since the initial vasectomy. So the best success rates are within 5 years of the initial vasectomy, but we still can consider doing a vasectomy reversal in patients who are 10, 15 years out. Alternatively, some couples may consider just moving straight to IVF using surgically retrieved sperm. Perhaps if there's a female partner that's a bit older, or if the female partner has been diagnosed with concerns about how well her ovaries are functioning. So we, again, want to take the big picture into how we counsel couples and aid them with their decisions.
Okay, so you take everything into consideration.
Yes.
Another question, what is the prevalence of infertility caused by any of the issues that we've talked today? in men? So, and also, what is the percentage of male factor infertility?
So this may surprise some of the folks out there in the audience that about 50% of couples with fertility challenges at least have a contribution from male factor. The sole male factor is the sole issue. And I think then people may realize, I think the burden often historically has been more so on the woman and the concept that it's the woman's problem. But that's why we have reproductive urologists. There's a significant portion of men who have issues with their sperm production and need assistance.
Okay, so just to make sure I understood this, 50% of infertility is there is a male contribution.
Correct. So it's a sole factor in about 30-35%, and it's at least a contributing factor in up to half of couples with fertility issues, meaning male factor and female factor.
That's very interesting, and I know that that is going to be very surprising for some people. And can you please share the proportion of men in the general population that may struggle with some form of infertility? Or they may have a fertility, they may have fertility issues potentially.
I'm sorry, I don't think I quite caught that question. Could you please repeat it?
So is this something that is common in men? Is this something that is extremely rare in men? If I took 10 men or 100 men out of the general population, what percentage of them may have an issue that may contribute to infertility?
So it's probably more common than people would believe. If you think about, than they would realize. If you think about the fact that 10% of couples trying to conceive have challenges, and then 50% of those are related to a male factor, it's not uncommon at all.
Okay, all right. Well, so we may be talking potentially about 5% of the population, potentially. I think, unfortunately, that Dr. Corri Tannrikut's her slide is frozen, so we're not going to be able to continue with her. Actually, it looks okay. Are you back?
Yeah. Yes, you're back as well.
Great. I'm sorry, we kind of froze for a second. But would you please continue with that? So I was saying it looks like perhaps about 5% of the population may struggle with an issue that would cause or be associated with infertility potentially.
Yes, and I think that it's important to raise awareness as you are, because this is something that men don't talk about with one another. So they struggle with it themselves. They may actually be even very closed off to their partner because they take it personally that they're having that they may be the causative factor, so to speak. Mm-hmm. So I think if we enlighten people, encourage them to talk and share their experiences and offer to them that there are options available, it will allow for patients who are afflicted with this to feel less isolated, less lonely.
So if you had 3 takeaways, because we are actually coming to the end of this interview, although I really am so excited and grateful that you were able to come on and talk with us today. What are 3 takeaways that you would share with any man or any partner who was watching this this live stream today? What do you want them to remember?
So I'd like them to remember that they should treat their bodies well, because if they're taking good care of themselves, they're taking good care of their sperm, and they're doing everything they can to optimize sperm production and sperm quality. I would encourage them, if they have any question of their family building potential, if they and their partner have been trying and haven't been successful, don't hesitate to request testing through their primary care physician for a semen analysis, or getting an over-the-counter semen analysis test as an initial screening, because the sooner we can initiate an assessment, the sooner we can provide options to the patient. And finally, I think it's important to be open and honest with the partner and with friends and family if there are issues and challenges, because there's no judgment. We're not looking at someone as less manly because of this sort of issue. It's a medical problem, and we're here to help.
Well, thank you so much, Dr. Tannrikut. Again, this is Dr. Corri Tannrikut from Shady Grove Fertility. She practices in Maryland and is available to, she's accepting new patients, right? I'm assuming you are? Okay,
yes,
great.
Absolutely.
And just to remind everyone, if you were not aware of it, the Cade Foundation does offer a family building grant that would provide up to $10,000 for any family that struggles with infertility, regardless of the cause. So information about our family building grant is available online at www.cadefoundation.org. We also have a Race for the Family hosted by Shady Grove Fertility that's coming up on Saturday, June the 16th at the Maryland Zoo. And for everyone who registers, you will be entered into a raffle to win $10,000 in treatment at Shady Grove Fertility. So if you're interested, please follow up at www.raceforthefamily.com or cadefoundation.org or shadygrovefertility.com. On that note, Coffee with Cade is all about conversation and not a presentation, and we do like to drink while we are having a conversation. So Dr. Tannrikut, if you will raise your mug and tell me what is in your mug.
Just simple black coffee. Keep it simple.
Simple black coffee. And today, my mug, I cheated a little bit. Mine is empty, but I'm going to put something in it in about 30 seconds. So thank you. And I'll see you next time. And Dr. Tannrikut, Corri, I will see you soon. You guys have a great day. Enjoy the rest of your lunch break. Bye.
Thanks for having me.